Welcome to Emergency Chaos, where we provide tips and tricks to make you a better ER nurse. Today, we are going over alcohol withdrawal, including symptoms, what questions you should be asking, treatment, and specific nursing tips. Thank you for joining. Well, we know that alcohol is a downer. It depresses the central nervous system. So when you withdraw, the opposite occurs, leading to increased excitability. I will try to explain the mechanisms as best as I can from my understanding. So, alcohol interacts with GABA, a primary inhibitory neurotransmitter in the brain, to cause more sedation. But over time, the body balances out the increase in alcohol intake with less GABA. So the body or the central nervous system isn't as depressed all the time. Also, glutamate, on the other hand, an excitatory amino acid, causes excitation when combined with NMDA. So, the body also tries to create homeostasis by making more glutamate receptors in an attempt to counterbalance the sedation from the alcohol. So those are the two compensatory mechanisms the body does when when the patient just drinks and drinks and drinks, right? So now that the patient stopped drinking, these compensatory mechanisms are still in place. There is less GABA to cause sedation, but a lot more of the glutamate receptors to cause excitation. So the result when the patient stops drinking is just excitation and a lot of hyperactivity with the central nervous system. So that's why the symptoms include tachycardia, hypertension, hyperreflexia, and tremors, as well as diaphoresis, delirium, confusion, they're super combative, and nausea vomiting. Symptoms can begin within hours, especially for those chronic heavy drinkers as soon as they stop drinking. Delirium tremens, the severe form of alcohol withdrawal, will show up around the second or third day. Know that just because your patient is in withdrawal, it doesn't automatically mean that they will go into DTs. But typically, from what I've seen, the really bad ones without any interventions get worse and worse. So why can withdrawal be so dangerous? Well, these patients probably haven't been eating or drinking anything besides alcohol, so they're already malnourished. Combine that with the nausea vomiting plus the diaphoresis and the body just being ramped up. It leads to dehydration, electrolyte abnormalities, and metabolic issues, just to name a few. And what ultimately can happen is the patient goes into shock or an arrhythmia or pneumonia or whatever happens, and they eventually die. Don't forget about seizures. The patient can get rhabdomyolysis, and they can even be a danger to themselves and to others that can lead to potential death, right? So that's why it is very dangerous and why these patients with alcohol withdrawal need to be treated promptly. Know that your patient can still be withdrawing even though they still have alcohol in their system. In other words, if the labs come back and the alcohol level is elevated, they can still be withdrawing. So patients who drink heavily on a daily basis can experience symptoms even just by cutting back a little bit. Remember that all the compensatory mechanisms present are used to these heavy amounts of alcohol. So when the patient comes back even a little bit, that's when the symptoms start popping up. So what are some important questions you need to be asking your patient? You need to be asking, when was the last drink? How often and for how long have they been drinking? And what do they drink? Do they ever have seizures when withdrawing? And you should even ask if they have ever gone into delirium tremens. You're going to find that your patients are very versed with their conditions. Let's say your patient states they have been drinking for the last 15 years, a whole bottle of tequila a day, and their last drink was 1 day ago. They also stated that the last time they tried stopping, they had multiple seizures. This should alert you that your patient gets sick and gets sick really quick. So you should devote more time to implementing all the interventions ordered, especially the medications that we are going to discuss shortly. A quick tip is that you need to check your patient's blood sugar if they are altered or confused in any way, not just for the alcohol withdrawal, but for any patient you come in contact that is altered or confused. Now let's talk treatment. The treatment of alcohol withdrawal is based around the replenishing of things that alcoholics often lack, like vitamins and fluids, then targeting the hyperactivity with medications that decrease neuronal activity and cause sedation. You give fluids to rehydrate the patient, as the patient tends to only drink alcohol, and that combined with the nausea and vomiting plus constant sweating and being worked up leads to them needing more fluids. You also give thiamine, folate, and a multivitamin again for the same reasons, because these patients probably haven't been eating adequately, only drinking alcohol. Many times you'll have a banana bag ordered, which is just the thiamine, folate, and multivitamins in a solution, which often contains dextrose. Again, because these patients just haven't been eating as they should. You want to place them in a quiet environment since they are already ramped up. But as much as you can try, this is hardly doable in a busy ER. There's always something happening. So now let's get into the meds. The primary meds used are going to be benzos, like lorazepam or otherwise known as Ativan. Benzos work by targeting GABA receptors, suppressing the central nervous system. Barbiturates work in a similar way to benzos, leading to a decrease in neuronal activity as well. The main barbiturate that you're going to see is phenobarbital. Benzos and barbiturates will work together to suppress the patient's hyperactivity. Most of the time, benzos will be first, and if additional medications are needed, phenobarbital gets added on. One thing that I do want to mention is that there are a few providers who choose to treat alcohol withdrawal with just phenobarbital. So just be aware that that can also happen. Your role as an ER nurse is to implement the interventions and to continuously monitor and advocate. If your patient needs more and other meds added onto their regimen related to their symptoms, your role is to have a conversation with the team to express your concerns. Of course, like always, CYA and document. There's also Precedex that can be used, but from my understanding, although it helps with the symptoms, it doesn't address the actual issue like the benzos and barbiturates do. So it should never be used as a sole treatment medication. Then, of course, if your patient is intubated, propofol is used, and it does, from my understanding, address the underlying issues like benzos and barbs. If your patient is in DTs and starts seizing, benzos and phenobarbital are used, and if intubated, propofol, of course, is going to be used as well. Now, let's get into specific nursing tips related to alcohol withdrawal. You're going to be giving your patient a lot of different medications that sedate them and suppress them. So you need to closely monitor for over-sedation, meaning you're monitoring their respiratory drive and mentation. There will be times when you have to give so many medications, but it ends up knocking them out to where they can't protect their airway. So you need to closely monitor them and communicate with the team promptly if this does occur. Another important topic is safety for yourself and the patient. Patients who are withdrawing are sometimes confused and agitated. Essentially, they're just not themselves. This agitation, combined with at times what seems to be superhuman strength, can be a safety issue if the patient targets the aggression towards the staff or towards themselves. So there's going to be times when restraints have to be used, but it should only be for the short term while the medications are prepared and administered. Of course, check with your own preceptor and facility for restraint guidelines. Next, you're going to need multiple IVs, ideally where bending won't affect the IV. For example, the forearm, since you are going to be giving a bunch of different medications. And sometimes the confused patient just pulls them out. So it's always nice just to have an extra IV, especially that's not in a fold, because they just won't follow commands. So if they're bending and this and that, having the IV in the forearm won't affect with bending, right? So I also like to always put seizure pads on my withdrawal patients just in case he seize on me. It's just an extra added layer of protection. Like always, if the patient is altered, check a blood sugar. Keep on closely monitoring your patient. Many of them will end up going to the ICU from how sick and busy they are. I recommend looking up and going over the CWAS score. It rates the severity of withdrawal based on the symptoms present. Know that your severe withdrawal patients can require very high levels of sedation medications. Of course, if on prop, keep an eye on the BP as propofol can lower the blood pressure. Then finally, give the thiamine before the dextrose to prevent Wernicke's encephalopathy. Okay, now let's head into the question of the day. What IV fluid is used for burn patients? Again, what IV fluid is used for burn patients? And as always, the answer will be at the bottom of the description text under the video. Thank you for your time today. I hope that I was at least able to teach you one thing. If you want to keep learning, I've listed my favorite ER nursing related books in the description, with my favorite being Sheehy's and the Case Files. As well, please take the time to watch my other videos. Also, if you would like to help support the channel, I have nursing stickers and shirts on Redbubble that you can check out. Again, thank you for your time. As always, here at Emergency Chaos, teamwork makes the dream work, and we are proactive, not reactive. Thanks, everyone.